am a microbiologist. So my doctorate spent 6 years in microbiology at UC Berkeley, studying how microbes design around antibiotics, heavy metals, antiseptics all day long. And then I transitioned and spent 7 years at Stanford as a rheumatology fellow, understanding all the microbial milieu and how that drives chronic, progressive inflammatory diseases. And then I started a company in 27, no, oh man, I'm really old. In 2009, when my grandmother had a stroke from a tooth extraction. It turned out her rheumatoid arthritis had progressed so much, and tooth decay set in. She had perio, and they extracted a tooth, and the next day, my grandma's quality of life completely changed. She was my best friend. So then, of course, what does a granddaughter do with capabilities? I biohacked her oral microbiome because after doing a lot of research at Stanford, realized that it's really the microbes that are driving this inflammatory reaction, right? And leading to tooth loss. And so after biohacking her for a while, came up with a bunch of things. And so today I'm gonna try to streamline what I've been learning. I won't talk too much about the immune response side of the story, although that's a whole other lecture in and of itself, but really focusing in on the microbiome itself and introducing you guys to the pathobionts. And yes, we don't have this slide deck yet in your curriculum, but I can send it to you electronically because I just finished it this morning. Terribly sorry, it's been a crazy week. So just go through a couple of different things discussing the oral ecosystem, how the microbes fit into that, and how we've been learning to modulate their activities over time and have a disease outcome that's good. So first, introduction of the oral microbiome. It is the second most diverse ecosystem in the body, the gut, lower gut being the first. And it is second most abundant microbial community too. So we're talking, 10 to the 12th, 10 to the 13th that a person swallows every day, originating from the mouth. It is the biggest driver of inflammatory disease states that we know of. If you add up all the dental caries in the world, gingivitis rates, and perio, depending upon country, 92% of people in India these days have perio. There's an epidemic problem. And what we're learning about the connectivity between the oral microbiome, like who's living in our mouth, who's able to really pry open and access the blood system through the gingiva to gain access to the bloodstream, is now being established in multitude of different academic research groups across the world. So we know that porphyromonas, or AA, and Prevotella are involved in all sorts of disease states: dementia, cardiovascular, preterm birth, diabetes or insulin resistance, autoimmune disease. And it's a pretty scary thing. And if you have gum disease, the top 3 things that could happen to you are cardiovascular events like my grandmother, diabetes, and premature birth, because the microbes don't just stay in the mouth. And the reason why is both what they're doing, the stress of the individual, genetic predisposition, and what clinicians do too. So my grandma had a tooth extracted, the size of a red blood cell is this big, the size of a microbe is this big. So hundreds, if not thousands of microbes could fit through a tiny wound in the gingiva. Everybody knows about, leaky gut, but leaky gums are just as bad. We just swallow the evidence. And people ignore it. So the microbes gain access easily to the bloodstream. There's a very big highway that goes to the brain. There's another big highway that goes to the heart, right? And so that's where they're going to cause problems. So really want to start to, I've been working with a couple of groups, mainly in the veterinary space, veterinary dentists, getting and working with rheumatologists to really come up with a better definition of what gingival disease really is from the perspective of a microbiome. And so it really is a polymicrobial community of microbes that are driving this inflammatory process, causing leaky gums in the process, recruitment of immune cells, which leads to periodontal disease and loss of integrity. It is really a deviation in your healthy oral microbiome, which is a process called dysbiosis, right? So we are born with our mom's microbiome. And so how the health and well-being of that drives what you inherited and what you will give to and impart to your offspring. And so the more diverse, the better in the mouth. The loss of that diversity actually and deviation away from gram-positive, so having a good amount of strep in the mouth is fairly normal. About 60% of a compartment should be about strep, multi-strep species, Streptococcus, you name it. But what happens over time as we age is we get this deviation towards heavy gram-negative anaerobes. And even, by the way, anaerobes can live in the tongue. They don't just live subgingivally like we're taught. We're finding them everywhere. And there's a shift from diversity towards an orange complex, which I'll talk about, and then a deviation and a migration towards red complex as disease progresses. And it strongly correlates with mucosal immune activation. Okay, so in this depiction, not from me, but from a dental research group, you can see that, I don't know if there's a pointer on here. Awesome. Okay, so if there's a wound in the mouth, if there's repetitive antibiotic, if there's stress of the individual, change in diet, you get introduced massive amount of a pathogen at one time, host defects, or certain genetics like transposons get introduced in the mouth. That can have a huge effect on the transition of that microbiome from highly diverse to more dysbiotic, where you get proportionate increase in pathobionts and disease. So then that, and that actually, so you get, everybody, as soon as we brush our teeth, within 2 minutes, those microbes are starting to reattach, right? And so you're not changing by doing a physical relocation of those microbes, they're still attaching. And then they reattach and they grow. And so what we do in our daily life affects how they aggregate, who aggregates first, how much plaque, the plaque burden, and that if there's too many microbes that are harmful or antiseptic resistant or antibiotic resistant, you're gonna get over abundance of those in insufficient numbers of beneficial over time, which really leads to all this accumulation of these pathogens and ultimately into a very inflamed tissue with correlates of bone loss and eventual tooth loss. So a little bit about the keystone pathobionts and gum disease. The orange complex is prevalently, we're seeing kids in 12 years old that are having signs of dysbiosis these days. In dogs, it's about 7 months. So there's a lot more Prevotella than there should be, a lot more Fusobacteria than there should be, and that transitions to red complex, where you're starting to see an overabundance of Treponema, Tenorella, Porphyromonas, which is one of the scary ones, because if you get, for instance, Porphyromonas, at levels even less than 1% of bioburden in someone's gingival, subgingival scraping, that can increase the entire virulence of that population that lives below the gum line. We're finding. So that's how potent some of these microbes are. And they can themselves transition a healthy commensal ecosystem into a pro-inflammatory state. And basically it changes not only what the microbes are doing, but it changes what they're eating and what they're secreting. And this completely winds up changing and causing the modification of host tissues, okay, into an immune-like state. So who are some of these players? So the red complex, so Treponema, it's Demicola, you guys might know. It's sister microbe, can cause syphilis, has ability to penetrate blood-brain barrier. Tenorella forsythia is a pretty cool bug, underrepresented, is present in a lot of people. If you're probably 65 and older, you probably have a decent amount of Tenorella in your mouth. Porphyromonas, we're seeing even, few months old kids having Porphyromonas in their mouths, and that's really not a good thing. Probably inherited from their mom. And they have things that can completely change tissue, modify their host environment, make them survive more and replicate more. And gingivitis are implicated in Alzheimer's disease, Peptidyl arginine deaminase is one of the main drivers of citrullination of host proteins, links to rheumatoid arthritis and periodontal disease. But you also have these commensals, such as Cutibacterium and Villanella, which should inhabit your mouth. But in the presence of any of those red complex microbes, will start to behave badly. You'll start to get a lot of, in the case for Villanella, osteoclast activation of the alveolar bone, and particularly in patients where you're doing dental implants, those guys you want to keep at a low level, and you definitely want red complex organisms to be very low if you're going to do anything to someone's alveolar bone. Cutibacterium causes periodontal disease in cats and humans. It's acne in humans as well. Loves to modify its host to create all sorts of inflammatory mediators that cause that stink and pus. When you pull a tooth, you're smelling the human's neutrophils, and you're also smelling what Cutibacterium secretes. So the mechanism really is, we live off of sugar. We eat carbohydrates every day. You guys know this. Your patients will probably consume way too many carbohydrates. But that has a profound effect on the ecosystem in the mouth, and it can take what we're normally taught in a healthy oral environment where the plaque is thin, the diversity of the microbes is high. That is good plaque. We want good plaque to inhabit the mouth. But in an area where either there's stress, there's presence of a high inoculum of, let's say, Aspergillus or Candida, or certain multi-drug resistant organisms like Porphyromonas, really resistant, we're finding in a lot of people's mouths. You're going to get a huge change in that ecosystem and the dynamics within the microbial community, and you're going to get an overpowering event because they're constantly battling for turf. And you're going to get a huge increase in acid production, glucan production, LPS, and an over-enrichment of harmful microbes, orange complex and red complex. Okay. And just for an example, it's a really complex system. It's a food web you just ate. So this is, you just fed your lactobacillus, your peptostrep, your strep, your staph. All those guys are fast eaters of carbohydrate. They secrete acetate, propionate, lactate, which then feed the orange complex microbes and the red complex microbes. So it's a chain of events. Okay, it's not just sugar growing these things. It's sugar being consumed by the primary fermenters in the mouth, which happen to be the majority of who lives in our mouths, and then secreting things within about 3 minutes. They're already starting to secrete those waste products to feed the other microbes that are really pro-inflammatory and driving disease. So this is why, one of the reasons why, periodic treatment or continued treatment with antiseptics or antibiotics are ineffective at really ultimately changing long-term disease outcomes in perio, particularly. So what you see is scenario is aging. We're all getting older. What we were learning over the last 30 years is that the microbiome changes as we age, and it becomes narrower and less diverse. That's called dysbiosis. Even someone who doesn't even get antibiotics or antiseptics will still experience this, and we're trying to figure out why. But the second scenario is, normal aging process. You're developing dysbiosis, but then you get hit with antibiotics. And in autoimmune disease, we know a person that got 3 major antibiotic treatments in their life, you can flare for the first time. So loss of diversity equals increased inflammation, accelerates and makes the dysbiosis more severe. Okay, and this is an example of how dental plaque, subgingival periodontal plaque from canine, when it gets exposed briefly to certain molecules like domopinol, dioxide, our approach, subtlepyridinium, which is in Crest toothpaste, or alcohol, which is in a lot of mouthwashes, how that responds, right? So in some cases, it's counterintuitive. You wouldn't think subtlepyridinium chloride actually enriched for the gram-negative anaerobes, but it did. This is a ton of Porphyromonas that survived. Okay, so that's just an example of how to think. And you won't know what patients have growing in their mouth, right? Unless you do diagnostics and profile who's in their mouth, which is one important thing to think about. And what we're doing is we're trying to actually increase diversity and grow the good. We want good plaque in people because we know they're going to help regulate the immune system. We know they're going to make tight junctions tighter, and that epithelial barrier will actually have barrier functions again. And we know that the waste products that they make, that we secrete while we're sleeping, they're spewing this stuff out and we're just absorbing it, really. We want that to be healthier for us in the long term. So what we're doing is really trying to change the oral palate to improve better outcomes. And we've developed 3 formulations so far that have gone through clinical work on the human side. And I'm excited today to tell you a little bit about what we're doing and how that's having an effect. So we're really trying to change the paradigm. We're not trying to kill. We're trying to take nutrients that microbes utilize and apply nutrient pressure. And that nutrient pressure will block, in this case, take this ecosystem that's, it's really a, I can't think of the name right now, spectrum, where anything coming in, like a lot of acid, a lot of sugar, you're gonna migrate more towards heavy carbohydrate eating microbes and the red complex and orange complex, or they're gonna make all these organics, you're gonna get enamel leaching, you're gonna get gums to be bleeding. And so we figured out and found a way to block that. So globally, we're blocking carbohydrate uptake by microbes in the mouth, even subgingivally, through a fiber that's produced by soil bacteria. It happens to be generally recognized as safe. And that is actually blocking pathogen foods, right? If you block, I just showed you a couple of slides earlier that if you block primary sugar fermentation, all those waste products that feed the orange complex and red complex, we're blocking that whole food web. And we're blocking acid production, which is healthier for your teeth and gums. And then simultaneously, we're stimulating the microbes, the good, to start eating protein instead. So basically, we're putting the oral microbiome on a little keto diet, okay? And that is creating more of an alkaline environment, neutralizing environment, more nitrites, and ammonias, and then it's actually growing good bacteria in people's and dogs' mouths. This is an example in real-time study where right after time 0, we hit them with a single dose of drinking water and put it in their drinking water, and then we measured by mass spec at different time points after that single shot what the microbe was doing. So we blocked sugar, so sugar should go up, and it did go up in the cavity. But importantly, over that 24-hour time course, every single amino acid except for L-arginine, which happens to be one of our key ingredients, to stimulate those microbes to start breaking down L-arginine amino acid. You can see they all fell. So the microbes started to really use the amino acids as a carbon source, which is great, because we know byproducts from that are less inflammatory. And then in more studies, we looked at 2 big cavity producers, Lactobacillus acidophilus, who you want growing in your GI tract, and strep mutans, which you guys know is one of the leading causes of aggressive caries. And in the presence of a single shot of faucet, you can see that over the next 24 hours, only the strep mutans can grow. Because lacto is like a Honda Civic. You can run, it doesn't, and like strep mutans is like a Lamborghini. It needs high octane fuel, and that's all it can survive on. You cut off that fuel source, it can't grow. It sucks at growing. But lacto can grow on, different kinds of fuels. And so that's all we're asking it to do. In another proof of concept study, L. rhamnosus, great microbe. It makes its own antimicrobial, so it keeps like the strep and staph at bay. So you want that to inhabit the mouth. And you can see in a quick exposure, again, a 24-hour time point, we're enriching for lacto. It's actually able to grow on a different nutrient source, even in the presence of sugar. In a dog study done not by us, but one of our partners in the biome, they did two different, they've done a ton of studies. These are two-shot snapshots at baseline and day 5 after drinking the drinking water with our dog formula. And you can see the really cool thing is that porphyromonas, this poor dog, both these dogs had relatively high, 42% and 16% relative to the total burden of microbe in the mouth. They had high amounts at the beginning and a significant decrease within 5 days because we're shutting off that sugar. The important thing that I like is we're expanding the diversity in the mouth too within that 5-day time frame. And another example, they've developed a really cool readout where they look for multiple organisms and made it super easy for customers, these are real-time customers buying their test. They can see the effects in real time after 30 days on our product, right? And they've done year-long studies with perio dogs, being fed all sorts of stuff. We did finish this during COVID, but you can see, again, demonstrating a significant reduction, multi-log reduction in porphyromonas, but we grew lactobacillus in their mouths, and beneficial microbes in their mouths. And this is an example of time shots of how good, like this is day 0, and this is day 14. Look at the reduction in gingival inflammation. You can see a slight decrease also in improvement in plaque. And this is day 60. You know, this is severe gingivitis. That one was starting perio. You can see it, we're rolling that disease state and that gingival inflammation back just by putting the microbes on a keto diet, basically. A little more complicated than that. But we've also done studies in humans. This is a multi-family study with children, adults and children. And you can see in their mouths, our approach really didn't alter the lactobacillus acidophilus levels. It just shut down the acid production. It also did significantly decrease strep mutans in that 5 days. And then also the gum disease organisms, it significantly reduced those in 5 days as well. This is study data from the clinical study performed in Alzheimer's patients, and we did a secondary study in orthodontic patients. And you can see that with our approach, even Candida does not survive. Candida is a sugar whore, okay? And by shutting down Candida's ability to take in carbohydrate, it can't compete, right? And there's no antibiotics that this Alzheimer's patient was given. So it's just a nutrient approach. And from baseline, you're seeing a deviation from baseline. So multi-drug resistant organisms are going down, lactobacillus is going up. I mean, we had some really scary multi-drug resistant enterics in people's mouths. It's crazy. You should see our freezer bank. But you know, these are good results, right? We're making the oral cavity a healthier ecosystem. Because a lot of these nursing home patients get skin and soft tissue infections, they get other things, and we're finding that the mouth might actually be the reservoir, okay? In a clinical study performed not by us, but in collaboration, we were funded by the National Institute on Aging, and you can see 6-week endpoints. We compared ourselves to sugar alcohols in the placebo group, and they just took a lozenge, releasing the ingredients to the microbiome 3 times a day, after breakfast, lunch, and after dinner. And you can see 6-week endpoint reductions for Pheromonas gingivalis and AA, and we maintain healthy amounts of other microbes that need to be in a human mouth. Oops. These are 2 bad boys, kind of scary, make a lot of toxins, don't want to swallow them. Also, plaque burdens went down. I said this was in the placebo group. This is chunky, thick, sticky plaque in those recipients, and the testnet recipient had much thin film of plaque inhabited by better bacteria. And then most importantly, the bleeding gums. So in that 6-week time point, 78% of the testnet recipients had no more sites of bleeding gums. So their BOP scores were much, much better compared to the 42% were in the sugar alcohol recipients where they still had bleeding gums, but they had a reduction in the bleeding gums, so we included them as a reduction. But we're still, I mean, it's just profound how changing a diet can have a vast effect on mucosal integrity, driven all by microbial food. The really cool thing is we're seeing also inflammatory markers of the host really improving. So we're seeing, in a single shot experiment again, where we give a single dose of profitol in this case, the indole level went up, which is awesome because that correlates strongly with healthy outcomes in gut health. And also TMAO went down. And TMAO is a very pro-inflammatory marker, correlates strongly with cardiovascular disease. It's actually a prognostic biomarker to look at for gum disease we're showing. And well, that paper will be written up and submitted shortly. But you're seeing a lasting effect on reducing TMAO in these people. You can also incorporate the powder, not just drink it, but you can incorporate it in O-ties. We've done a bunch of device studies, so we've done a liner elution and O-tie elution, and you can see either the high dose or the low dose changes the plaque. So when they go to the orthodontist and get, the worst thing to do when you go to an orthodontist is get cavities because your kid isn't brushing their teeth like they should, right? So we're working with orthodontists to develop fast-eluting devices that can really improve what the microbes are doing at the time brackets get put on or O-ties get changed out. Or aligners, you should see what grows on the liners. But it's all about managing that biofilm. And segueing into more systemic, just kind of wanted to tell you a little bit of the anecdotal things that we're learning. So like, people are telling us, or physicians that are using or have prescribed our stuff, have mentioned that tooth sensitivity usually improves, of course, because microbes aren't secreting that acid, which causes tooth sensitivity. The canker sores or lesions are better. Tartar is going away. Chewing doesn't hurt anymore, which is really, we're hearing a lot from the elder dental populations. They can eat foods again that don't cause lower GI issues. So what you swallow also impacts gut, right? So if you have dysbiosis in the mouth, they've shown you're going to get gut dysbiosis. Or if you have gut dysbiosis, high likelihood that you're going to develop oral dysbiosis. It's just a tube with two ends, and microbes transit from one end to the other. Also, interestingly, we're seeing a lot pop up from the urinary tract infection and skin. So I want to talk a little bit about what we're seeing. So we've been getting a lot of skin and soft tissue infection patients, and a lot of them are dogs that get refractory hot spots. We treat their mouth and the skin at the same time to get rid of it. And you can have significant resolution. In this patient actually had MRSA and MRSI at the same time, which is methicillin-resistant staph epidermidis and staph aureus cellulitis. And we treated his mouth and the lesion, actually the vet did, and twice a day, and you can see within 10 days he was fine. Same thing with this dog. Same thing with this former IV drug addict who contracted MRSA. He was out of Baylor University, and the dermatologist was unable to treat him. Basically, tried all the experimental stuff on the market or in development, and it was refractory. So we were, luckily, his aunt knew about us, and we worked with the dermatologist. And you can see we treated his mouth, because that's where it was in his throat. And we treated the skin lesions at the same time, and he's never had to come back. So this was a huge success. And from some of the work in elder care, we know that patients receiving our active compared to the standard control did not have urinary tract infections on our product. It's because microbes can spread, right? This is a sample from a woman at baseline. You can see there's a lot of gram negatives in there. Gram negatives should not be in the vaginal cavity. And you can see within 48 hours, there's hardly any gram negs present. It's mostly gram positives and mostly lactobacillus. And the tissue scrapings were a lot healthier looking, right? That's just by putting the microbes on a keto diet in the vagina and in the mouth. Okay? So there's this huge continuity between the mouth and the body. And yes, it's going to be an indirect route, but it is a route. And it keeps on popping up in our dog studies, and our cat studies, and our human studies. And by treating the mouth, and perhaps treating other areas as well, you can have a profound effect on clinical outcomes. And that's what I really want to talk about. So I'm happy to take some questions. If there's any, you guys have any? Yeah.
So are these lozenges or something you add in the water, or what are they?
Both.
Okay.
Yeah, we're coming out with water additive lozenges and effervescent cleansers.
So with our
Toothpaste as well.
so with our geriatric population who can't take care of their teeth, this is what you would recommend
Yeah.
to reduce the.
Yeah, my grandma couldn't brush her teeth. She couldn't do anything. So the lozenge, at least she could suck on that after she ate or drank anything throughout the day to keep on the, blocking those microbes. And, you know, in elder care, honestly, no one, you know, we've been fighting this battle for a long time. It depends on the state and the laws of each state, but your average orderly or nursing staff cannot brush. They just can't get to brushing the teeth once a day. Yeah, there's and even from all of our standard of care studies in dental, even if you do brush, you can brush and floss all you want. You can have no tartar and no obvious plaque and still have rampant gum disease. So it's not a plaque and tartar driven thing. It's not a brushing thing. It's a subgingival where nothing else can go. Our nutrients can go down that far. Yeah.
So you talked to me on air about like antibiotic resistance. Can you just kind of like talk about that a little?
Yeah. Okay. So what we know from all the meta-analyses is if you hit a host with antibiotics, it can be either a broad spectrum or a narrow spectrum, you will fundamentally affect the microbiome, and it will change, and it will have a lasting effect on who lives in that ecosystem. And what they're doing, because you just shifted the careful balance that was established, that they self-established. You just completely shifted it, because let's say you used a gram-negative specific or a gram-positive specific. You just got rid of a huge swath of microbes, except for the ones that were already naturally resistant to it, or capable of surviving the stress because the dosage wasn't right, or maybe it didn't penetrate as well down subgingivally, perhaps. And they were able to survive that. Once they learn how to survive that, they learn. So that's why xylitol is very ineffective. Is the microbes learn, oh, it's a carbon source, I'm still going to utilize it. So it can grow. You can isolate strep out of people's mouths that can only grow on xylitol now, as an example. The amount of extended spectrum beta-lactamase gram-negatives that are enteric that we are seeing in people's mouths is insane. So take into consideration how you apply antibiotics. You want to hit them fast and furious, and then also be mindful that in rheumatology we use antibiotics to directly treat the immune response. So you're not just hitting the microbe, you're also affecting the immune response too when you're using certain antibiotics, which is something to be thoughtful about. What we're actually investigating is the use of our approach as an adjuvant, so you don't need to use as much antibiotic, just to preserve gut health, right? Because a lot of oral antibiotics are systemic, right? So you're going to affect the gut just as much, and that can lead to C. diff in vulnerable populations. I know you have to treat with antibiotics prophylactically for joint replacements, heart valves, which is a good thing, because you have transient bacteremia when you get your teeth cleaned. And so you definitely want to limit the downside, because there will be a downside. And it's either dysbiosis or it's bacteremia that leads to a flare if you're not an immune patient, right? Because any microbe that is big enough signal in your blood, your immune system will go nuts, and you'll go through that acute phase immune response. So you want to be very mindful about dosing, targeting it. You can, I love the concept of minocycline packs. Too bad they don't work. Microbes are just laughing at the minocycline these days. So there's more thought needs to get put into this, but patient care is number one. You just have to weigh the risks and the benefits. And definitely you have to, because MRSA is coming from our drinking water. So they're using dioxide to clean the water supply, but it only works on enterics that aren't resistant. And MRSA is gram-positive. So is Candida. Fungal spores we're drinking. Amoebas in our water. It's yeah. So, and it's something that you have to do every day. We've done double crossovers in dogs, and we know they're gonna get their microbiome back. Because there's always a seed somewhere. We don't know where that reservoir is. You can blast them with the strongest antibiotics in the world. You're never gonna get rid of that node wherever they're hiding in the mouth. And the fecal transplant studies have shown that. Now there's groups looking at oral transplant. That'll be interesting to see how that works. There are groups that have done probiotics. Those don't work because all the spaces are occupied. Unless maybe if you issue it with a antibiotic at the same time to clear up some of that space. But odds are the antibiotic's going to screw up that probiotic anyways. And then our approach is compatible with probiotics. Yeah?
When can you expect this to be in the market?
Hopefully soon. We're trying to get, you can demo some today and tomorrow. We're going to be having a module, but we're hoping to launch very, very soon. It's literally in production. Right now you'll see the unsexy packaging with the transient label, but we're working on getting the good stuff in. Yes?
Is there any scope to combine this with the prebiotic benefits of CTP and ACP?
What does that stand?
So NIPAS, I think it's called here. So calcium phosphodipeptide and all this calcium phosphate. There's some research coming out of Melbourne, I believe, about fostering or supporting the sanguinus. Helping to move things along that way.
Mm-hmm.
I guess if research hasn't happened on the combination yet, is that some research that could happen?
Yeah, and I would prefer that they use the bacillus species instead of strep is really pro-inflammatory. It's lipotycoic acid, and the way it modifies its outer surface, it's very gram-positive, so it's got a lot of protein on the surface. In an unhealthy environment, that outer surface actually gets modified by host and porphyromonas pads, peptidyl arginine deaminases. So that arginine gets transferred into a citrulline, and then boom, it's a foreign epitope. So in rheumatoid, this science paper that my old lab at Stanford just published actually showed that people with periodontal disease and RA had, during these microbial flares in the bloodstream, during a flare they get transient bacteremia, or during periodontal disease they get transient bacteremia too because of the leakiness of the gums and thinning of the gum tissue. And those microbes were actually highly citrulinated, and the patient's immune system reacted against the microbes themselves in a much more robust way that triggers all sorts of, I don't know how simple, it's harder for me to simplify it, just layers and layers of activation, immune activation. And so what basically, it would have to be, I would want to genetically modify it to knock out a certain couple of genes before sanguinus would be appropriate. I feel before I would feel comfortable. But bacillus, any day. Lactobacillus, all day long. Yes?
If someone comes in and gets their teeth cleaned at the dentist, and you do a very thorough prophylaxis, would that be the best time to start someone on this? Because I think about the biofilm is just immediately reforming once they leave. That seems like the ideal time to start them on something.
Yeah, I mean, you guys know the general burden, simply reducing the burden. So by putting a person on antibiotic, you're reducing the burden, but you're not getting rid of the microbes. You're just reducing the global burden in that mouth. That has an anti-inflammatory effect because in perio it's so high, really upsets the immune system that you're just lowering it below a certain inflammatory threshold. So you're seeing some gingival benefit, but that goes away in a couple of days. Right? Or a couple of weeks. In dogs, it's literally 3 days, 3 or 4 days. So I do recommend putting them on after a dental cleaning. All of our veterinary studies are built that way, and you do see lasting effect, but they have to take it every day because it's an everyday struggle because we're all eating carbohydrates. And these microbes upregulate all sorts of carbohydrate genes. And so the minute we plug them up, they've already started to upregulate the genes to express more so that the next time their host takes in any more carbohydrate, they can still survive. So that's why we have to hit them multiple times throughout the day. You know, because we're not, the good thing is microbes will never design around sugar. So there's no resistance profile with what we're doing, because we're literally just, they think that they've grabbed sugar on it, just happens to be in a big fiber molecule that they can't fit into the sugar transport systems, and it's same thing with the exoenzymes that form the dextran chains and chains in the plaque. They think it bound glucose or sucrose, but in fact it bound this big fiber with these glucose molecules hooked in covalently, so they don't ever get chopped. And they're literally plugged. So it's a non-fermentable fiber that blocks all global machinery. And then we're stimulating the microbes just to start on that L-arginine with the vitamin B6, which is essential for the machinery in the microbe to start chewing on and breaking down amino acids. So yeah, it's great after a cleaning to just douse the mouth. Yeah.
Like a daily supplement, so for
Yeah.
a lot of our elderly patients, they're really concerned about finance. What do you anticipate the over-the-counter cost for them to be?
Yeah, our goal is to be way less than $1 a day for the water additives. Okay, and we've done compatibility studies with the thickening agent for memory care. Like the lozenges are fine for early stage dementia patients, but after they're having choking issues, you want to remove that and just put them on the water diet. It's good if they're above. You can't. The beautiful thing about these nutrients is you can't overdose on them. We're just treating the microbes, so it's like literally the amount in this bottle was 1/2000 of my daily recommended intake for vitamin B6, and the fiber, it's not going to cause issues because it's just tiny amounts of fiber. It's just literally to plug up the microbes. And the amino acid in here is less than 5,000 for RDA recommendations, and that's it. Those three ingredients. Our lozenges have on board bicarb and calcium to start to reestablish the enamel, but this is just the microbial juice. Any other questions?